Patient details. Mr. X, a 55-year-old gentleman, who is a section officer in geophysics, resident of Varanasi, UP, Hindu by religion, presented to our OPD, surgical oncology OPD, with the chief complaint of ulceration in the right buccal mucosa for the past 3 months. Coming to the history of present illness, ulcer in the right buccal mucosa for the past 3 months, which was gradually increased in size of starting from the size of 1 into 1 centimeter to the present size of 4 into 3 centimeters. Ulcer was also associated with the pain localized to the oral cavity, which was aggravated on taking spicy food and relieved on taking analgesics. There was no history of any reduced mouth opening, no history of any pain radiating to the ear, no difficulty in swallowing or mastication. There is no history of any pus discharge or any fever, no history of change in voice or difficulty in swallowing, no history of any sharp teeth or ill-fitting dentures, no history of any significant weight loss or loss of appetite. There was no history of any previous radiation exposure, and there was no history of cough, hemoptysis, or bony pain. History of past illness. Patient also gives the history of whitish plaque in the right buccal mucosa, which was non-progressive in nature and had underwent an excision of the plaque 5 years back, but he doesn't have any histopathology record of the same, and he has taken some oral medication post excision for 1 year. Is also known case of type 2 diabetes mellitus on oral hypoglycemic for the past 3 years, and also a known case of benign prostatic hyperplasia on treatment for the same for the past 5 months. He has also undergone hemorrhectomy in the surgery in the 7 years back. There is no any drug allergy. Coming to personal history, he is married. He consumes kini chewable tobacco for the past 25 years, and he has stopped for the last 3 months. He also smokes cigarettes, approximately half a pack per day for the past 20 years, and he has stopped that for the last 3 months. It is according to amounting to around 10 pack years. And he also consumed alcohol occasionally, vegetarian in that, and there is no other significant history of malignancy in the family. To summarize my history, a 54-year-old gentleman who is a chronic tobacco chewer and a cigarette smoker presented with a history of progressive non-yielding ulcerative lesion in the right buccal mucosa for past 3 months, with a history of excision of whitish plaque in the same site 5 years back. Coming to examination, conscious orient patient was examined in a broad daylight with informed consent. He was conscious, oriented to time, place, and person with the performance status of ECOG 1, and his vitals were stable. There was no any pallor, cyanosis, clubbing, jaundice, or any generalized lymphadenopathy. This is the intraoral picture of the patient. We can see the growth. On inspection, intact facial symmetry with no skin changes over the face and skin. Mouth opening was 3 finger. There was a poor dental hygiene with halitosis and tobacco stain present on the teeth. Dentulous oral cavity. Tongue was normal. There was no wasting of vesiculation or any deviation. Coming to growth specific, there was an ulceroproliferative lesion with everted edges over the right buccal mucosa involving the lower GB sulcus and lower alveolus measuring around 4 into 3 centimeter. It was situated where anteriorly it was 3 centimeter posterior to the right commissure, posteriorly just reaching the right retromolar tigol. Medially, it was involving the alveolus from the second premolar to the first molar teeth, which was 0.5 centimeter away from the gingivo-labial sulcus, and floor of mouth was free. Skin is uninvolved. Lower GB sulcus was involved, but upper GB sulcus was free. There was another 2 into 1 centimeter ulcero-infiltrative lesion in the same right buccal mucosa, which was in continuity with the index lesion. It was just anteriorly, it was 1 centimeter posterior to the commissure and 3 centimeter to the right of the left central incisor. Posteriorly, it was in continuity with the above mentioned lesion. Medially, it was reaching the lower GB cell. Palpation. There was no tenderness or local rise of temperature. Inspectory findings were regarding the dimensions were confirmed, but there was a induration beyond the visible extent of the disease up to 5 mm, and paramandibular disease was seen from the right molar till the first premolar, and also gingival labial sulcus and the floor of mouth was free. Overlying cheek skin was free, and rest of the oral cavity apparently normal with no patch ulcer or submucosal fibrosis. On coming to neck examination, single 1 into 1 centimeter right level 1B node, which was hard in consistency, mobile, and overlying skin was normal. There was no other neck swelling. Bilateral common carotid pulsation were normal. Hopkins examination could not be done. Coming to systemic examination, respiratory, CVS, and CNS examination were essentially normal.
Have you missed out anything in the examination? In the local examination? Have you checked for the sensation over the chin?
Yes, sir. I'd look for the sensation, sir, but there was no history-wise. He didn't have any loss of sensation in the history-wise. Sir.
What does it signify?
Sir, it signifies in involvement of the inferior alveolar nerve or the mental nerve, which when the
Involvement of the?
inferior alveolar nerve, which
So
comes
which
out
branch
from
of inferior alveolar comes there on the chin? Which supplies the chin?
the mental nerves, which is a continuation of the inferior
Right.
alveolar
So
nerve.
it's a clinical indication where you suspect mandibular involvement.
And what about bimanual palpation? I don't see it.
Skin palpation I mentioned on the
No,
the
you have a buccal mucosa going to alveolus, so I expect you to palpate the mandible bimanually. You should
to
always
summarize
do
my
that.
case. Yes, sir. To summarize my case, a 50-year-old gentleman who is a chronic tobacco chewer and a cigarette smoker for 20 years, a progressive non-healing ulcerative lesion in the right buccal mucosa for past 3 months with a avoided edges, indurated base extending beyond the margin of ulcer, with a history of excision of the white plaque in the same site 5 years back, along with a mobile ARD ipsilateral level 1B lymph node. It's a good mouth opening. I'd like to give my provisional diagnosis as a malignant lesion of the right buccal mucosa involving the lower GB circus and lower alveolus with a clinical staging of T3N1 M0. But I would need a radiological investigation to know about the bone involved.
Because you didn't do a bimanual. What investigations?
Yes, sir. First, I would like to confirm my diagnosis with a biopsy of the lesion, where a punch biopsy of the ulceroproliferative growth, followed by
There are
CT
two
scan.
distinct lesions. One is a ulceroproliferative, the other one is ulceroinfiltrative.
Yes,
So
sir.
why are you taking biopsy only from the one and not from the second?
Sir, actually, the lesion is in continuity with the same lesion, even though the nature of the lesion is different. And again, even if I take a biopsy of the infiltrative lesion, if it comes benign or non-malignant, I would still
Then
go
how,
with the management of.
excuse me, how do you say then there are two lesions then, if they are in continuity?
Ma'am, the nature of lesion on if we observe, ma'am, actually it's a proliferative lesion. Here it's a infiltrative lesion. Even though it's in continuous, but the nature is different. But uh, uh, it's not the same as the proliferative lesion, ma'am. But as I was telling, the biopsy of my infiltrative lesion, even if it comes out non-malignant, I would still include in my resection specimen. So biopsy can give a better idea, but still I would consider I would be involving that lesion also in my surgical plan.
What are the changes that you see around this ulceroinfiltrative lesion that you say?
Surrounding to sir, one I can see the induration even on the infiltrative lesion, sir. That
Above the lesion. Do you see something above?
there is a
And what is the finding on the commissure? What do you see on the commissure?
actually there was no lesion. It was almost reaching. It was on here. It
So
appears like there
what
is a
is seen
whitish
on the
flag.
commissure? So what is seen on the commissure? It's not the normal mucosa that you see.
It looks like a whitish flag.
And you see similar lesions just above your ulceroinfiltrative lesions.
So there is a whitish flag. As I said, sir, the he had an history of actually he gave a history of plaque lesion. It was at this site only, sir. So there was no growth per se for the past 5 years after the excision, but there was a small discolored whitish discoloration was observed.
No, no, you are swaying away from what Professor Pandey has asked. What is that white lesion and why you have not mentioned it?
It was a probably
And
a
is it important or not?
yes, ma'am. It's a potentially malignant disorder like leukoplegia, which is considered as a potential malignant condition.
It's look like a field change.
Yes, ma'am. He had that for the past.
There's possibility of a field cancerization.
Yes,
So what is the role of panorex in today's era? You have not
ma'am.
mentioned.
Actually, earlier days, panorex was done to look for the mandible involvement. But CT has replaced the panorex, where actually by doing a CT scan, the lesion which was not appreciated in panorex also. So like more than the 30% involvement is needed for proper appreciation in panorex, but which will not be.
Anything else you see in the panorex?
Vertical height of the mandible can also be appreciated, but it can
And
also be done by a 3D reconstruction of the CT also, which can be.
I understand, but still, and what else can you appreciate?
Usually in the management of marginal mandibulectomy, the extent of mandible can also be seen, but again, CT can give that same information. So nowadays, panorex is not.
What about teeth? Does it give you any information about teeth? And is it important if the patient most probably will require radiotherapy?
If there is any dental loosening of teeth or any
Not lose. Yeah, so they have to
alveolar
be
erosion. Yes, ma'am.
they have to be treated prior to radiotherapy. Otherwise, what?
Ma'am, dental caries is the complication which is seen.
Can
Chalo,
you
aage chalo.
can you describe the teeth in this particular patient? Starting with the incisor and going and telling me ki what are the findings that you see?
Sir, there is no loss of teeth. All the teeth are present, but starting from the incisor, there is a partial loss of teeth. Partial loss of teeth on the lateral incisors, lower lateral incisors in this picture, and tobacco staining, chronic tobacco staining is seen, and also in the upper alveolar ridge on the third molar, there is a loss. Actually, there is a caries of teeth where the blackish. It's not very clear in this picture, but even the teeth is present, but there is a caries of that last molar.
And what's on the tongue?
Tongue, sir, there is like the oral hygiene is poor, sir. There is a whitish patch, but actually I have seen examined, sir, but there is no leukoplastic patch in that, but only the.
Is there melanoplakia on the tongue?
It looks like in this picture, sir, but I have not taken a proper representative picture.
So you
Teacher,
will
what are
do
the
it by
signs of
biopsy.
submucous fibrosis?
Sir, starting from early grade, sir. Usually in a grade 1, where patient will have irritation and just burning sensation feeling.
Signs I asked.
Sorry, signs, sir. Signs, there will be vertical bands of fibrous bands on palpation, which can be appreciated, and on inspection there can be trismus of the difficulty in opening of the mouth, and in early lesion, a simple erythematous, just hyperemia of that mucosa can be seen.
What happens when you press a normal mucosa and leave it? And what happens when you do it to the submucous fibrosis?
The capillary refilling can be appreciated in a normal mucosa, but in submucous fibrosis, due to the fibroblastic activity,
So what is it called?
branching of the mucosa, it cannot be appreciated in the mucosal fibrosis.
What happens to the tongue?
Is submucosal fibrosis, tongue.
What are the clinical things that you observe on the tongue in submucous fibrosis? Submucous fibrosis does not only involve buccal mucosa, it involves other structures also. So what are the features in the tongue? What happens to the palate? What happens to the soft palate? What happens to uvula?
And lastly, teeth.
Loss of taste sensation can be seen, sir, and also movement of tongue can be restricted with the sense higher
After
rate
you
of.
finish, we will ask Shweta. Okay? चलो अभी आगे बढ़ो because time is limited.
On my on biopsy, it came out well differentiated squamous cell carcinoma, and also CT of the oral cavity and the neck was taken. Here we can appreciate right buccal mucosa in the posterior aspect seen in the image.
Is the mandible involved in this plate?
Sir, actually, I need a bony reconstruction, like a bone.
You have it?
Yes, sir. I have it, sir. This is the coronal image, and this is the bony image, sir. There is no cortical erosion is seen.
Because you don't see it because you have taken it at the level of the teeth. It is not at the level of the mandible cortex. It is at the level of the teeth. So at the level of the teeth, you will not see inversion of the bony. So when you are showing a bone cut, you should show it at the level of the cortex.
It's a lower cut, sir. Again, the cortex is intact.
Go further down. I can still see teeth. You have to go below the root. So according to you, there is no involvement of mandible.
But there was no cortical erosion, sir.
There was no cortical erosion. Okay.
So the report was 5 into 2 into 0.9 centimeter in growth, the effective growth involving the right buccal mucosa extending into the right lower GB plus and lower alveolus without any involvement of femtotype and no bone erosion. And also 1 into 1 centimeter right level only lesion. Test actually was within all the routine investigations were made. So my final diagnosis is carcinoma of right buccal mucosa, stage AJCC according to 8th edition.
Keshav, can you speak a little loudly?
Sorry, sir. Yes, sir. My mic was little lower, sir. Yes.
So what will you do, Keshav, with this diagnosis?
I'll discuss the plan with the patient. This patient, the best modality will be surgery. I'll consult the patient regarding the modality of surgery and need for the adjuvant treatment, if any, based on the final histopathology report. I would offer lip split, a cheek flap approach with a wide excision of the growth with the marginal mandibulectomy and reconstruction with a radial free free radial forearm flap, sir.
So you think after doing the marginal mandibulectomy, radial forearm with excision of the whole of the buccal mucosa is going to be sufficient?
Actually, the buccal mucosa extent is not too much, sir. The defect will come around 6 into 4 centimeter. With a, I can have a 6 into 4 centimeter. I'll involve my reconstructive team plastic surgery also. With a defect of 6 into 4 centimeter with extra of 1 centimeter. Radial forearm free flap should be feasible, sir. Otherwise,
So you mean to say you are going to leave the some part of the buccal mucosa behind?
no, sir. I'll completely cover the buccal mucosa defect and cover the marginal mandibulectomy cover also, sir. Like I'll be covering completely, sir. It with the flap, I should be able to cover, sir, the free radial forearm. If it's not possible, I'll definitely have an option of ALT flap also, sir. If it's needed.
So why did you choose a radial forearm in the first place over
Uh,
ALT? What are the advantage and
yes, sir.
disadvantages of choosing a radial forearm?
Yes, sir. Sir, ALT flap yeah, can be little more bulky and it can hinder in the patient's achieving also, sir. And there is no need for such bulky reconstruction. A facial cutaneous simple radial forearm flap will be able to do that job. Although fasciocutaneous ALT flap can also be raised, that is also an option without taking the muscle. That is also an option, sir. Otherwise, it is easy to do and it can be an option.
How will you assess a patient for radial forearm flap in your clinic? And what instructions will you give to the ward or nursing staff?
Yes, sir. Allen's test is done to look for the patency of the vessel, sir. And also, I'll instruct that they
Did you
should
hear
not.
me?
Yes, sir. Allen's test is done to look for the patency of the vessel, sir. And I'll instruct in a ward that and also to the patient that there should not be any insertion of the IV cannula and there should not be any injury to that particular arm where flap is being planned, sir.
Okay, Keshav. So why didn't you think in terms of dental rehabilitation at the time of?
Yes, sir. Actually, sir, before going it with a surgery, I should have a MDT team where dental rehabilitation, speech and swallow therapist counseling, and yes, sir, that should have
So
been done, sir.
how would you do it?
Dental rehabilitation, surgical wise, since I'm not in my management plan, that I won't be removing the segment of the mandible, the marginal mandibulectomy. But a prosthodontist can help me in post surgery to have a implantation of the teeth, and patient can achieve achieving like
Why you are thinking of post-surgery rehabilitation, not intraoperative rehabilitation?
operative, sir. In a marginal mandibulectomy specimen, the implantation of that metallic. Actually, I'm not aware, sir. I should. Uh, Prosthodontist, the post surgery can also be done, but intraoperative in a marginal mandibulectomy where raw bone, I'm not sure about that, sir. I said,
So if you are going to do in post-operative period, the bone will not be raw.
sir, the flap will would have covered, and there will be healing, and fibrosis would have developed on a later stage, and there wouldn't be any fracture like later. I'm not exactly aware about that, sir, but I should discuss with the prosthodontist, sir.
Okay. What about adjuvant treatment?
Yes, sir. Based on the final histopathology report, if my tumor, if it comes pathologically T3 and the N1, which is clinically positive, if it comes node positive, patient would need a if he has and the margins are negative, and there is no extra capsular spread, uh, patient will require adjuvant radiotherapy, sir. Of around if it's based on the low risk or high risk, yeah, up to 66 to 70 gray of yeah, RT is given in a fraction of 30, like 5 days in a week for 6 to 7 weeks, sir.
Okay.
Will you give adjuvant radiation or adjuvant chemo radiation?
Sir, adjuvant chemo radiation, if my margin is positive and if I can't go back and remove, and if there is extra capsular spread, in those conditions, I have a indication of CCRT based on the RTOG and 9501 EORTC 22931 study people.
Suppose this patient comes back to you after 4 or 6 months after surgery.
Yes,
What
sir.
all, and of course completing adjuvant treatment, what all will
Yes,
you look for in this patient?
yes, sir. If my patient doesn't receive within 6 weeks, few studies have shown up to 11 to 12 weeks is the waiting period. If the patient comes beyond that 12-week period, I would go ahead and restage. I would get a CT scan
No, no,
of
I'm
the.
not saying that patient has gotten radiated. He's completed treatment.
Acha,
Now he's come to you in follow up at 4 months or 6 months.
yes,
What
sir.
will you look for? What all will you look for in this patient?
Yes, sir. Yes, sir. Sir, after completion of the radiotherapy, in the first 3 months, we get a basic CT scan is needed, sir, to look for the which is non-clinical. I would do a clinical examination first. I'll look for the oral cavity, if there is any signs of any recurrence or any second primary which is visible in the intraoral. And I would look for the neck, if there is any swelling in the operated side or in the opposite contralateral side. And also, I would get a CT oral cavity and a neck to look for a non-clinically visualized if there is any recurrence or a second primary which can be picked up by the CT.
Will you do a thyroid function test in this patient?
Post RT, patient can have a hypothyroid, which is yes, sir. Yes, sir. It should be done, sir. In the radiation field, the thyroid would have ablated, and
Thyroid comes in the radiation field.
sir, covering the level 1 to 3 lateral patient, it won't reach the medial middle part, but if you are not giving IMRT, sir, conventional old techniques can have a thyroid field can be, but nowadays IMRT is be the standard of care where it's avoided, sir. If patient has received IMRT, it's avoided, sir.
Sir, we'll see the blanching of the mucosa, and we'll see the fibrotic bands on palpation. We'll see the fibrotic bands palpation in the labial mucosa, in the buccal mucosa also, and in the severe cases in the retromolar triangle area also. And restricted mouth opening. With regarding to the tongue, there will be restriction of the tongue mobility. And with respect in the soft palate, there will be hockey stick appearance of the soft palate, sir. And sometimes we can see the erythematous lesions also, erythroplakia might be seen, sir, along with the OSMF.
And you may
And
see a bald tongue also.
okay,
You may
okay,
have
sir.
a loss of papillas on the tongue.
Yes, sir. And due to sir these habits, these patients might be presenting this adhesion of the teeth, sir, with either the fractured, like in this patient, we have seen the adhesion, generalized adhesion have been seen in all of the teeth, and in the lower teeth, we have seen the tobacco staining also, and we have seen the fractured anterior segments also, secondary dentine formation in the tooth also, sir, we have seen. So in these kind of patients, we see these teeth changes.
There is a classification system also, na? I used to read some
Ma'am, they
1 to
have
5 clinical.
ma'am. Yes, ma'am. Yes, ma'am. They have divided it into grade 1, 2, 3, 4, 5, in
Yeah.
which in grade 1 only the oral blanching of the oral mucosa will be seen with no other symptoms. And in grade 2, there will be, along with the blanching, there will be the burning sensation of the mouth. Patient usually present with the burning sensation. This is the clinical features of the patient when he or she, when the patient presented us to in the OPD, along with the dryness of the mouth, and sometimes patient will be seen as will be having vesicle formation on the buccal mucosa or on the tongue, and ulcerations in the mouth also, ma'am. And in the grade 3, there will be restriction of the mouth opening along with the other grade 1, grade 2, matlab grade 1 oral blanching, grade 2 oral blanching plus burning sensation, dryness of the mouth and all, along with the vesicles or ulcerations. And in grade 3, along with grade 1, grade 2, there may be restriction of the mouth opening, ma'am, without tongue involvement, ma'am. And in grade 4, there will be tongue involvement. And in grade 5, there will be there will be a ulcer that will be histologically proven as carcinoma, ma'am. And along with that, there will be the different treatment modalities that we give for in grade 1 to grade 5 is, if there is only oral blanching, then we will give the patient antioxidants and multivitamins. And sometimes we used to tell the patient to eat tomato also because it contains lycopene, ma'am. And in grade 2, along with the blanching, they are having only the symptomatic reliefs we will give, ma'am. For dryness, we will give some.
Shweta, you left out the most important treatment,
Uh, okay, sir.
habit cessation.
Yes.
Okay.
And amongst the signs, we did not say shortening of uvula, which characteristically appears in some
Sir, I said hockey stick uvula, sir. Hockey stick uvula presentation of the soft palate, sir.